insulin resistant is a term that's used because the blood glucose goes high and the body doesn't like it so high. So it makes more insulin to sort of allow it to go in. So one of the actions of insulin is to allow glucose to go from the blood into the cell so that the cell can use it for energy. Insulin resistance is a term that they use when they say, oh, well, there's lots of, glucose in the blood and there's lots of insulin, so why is it not going into the cell? So they say the cell must be resistant to the effect of insulin. And you can think of it like, suppose you have a restaurant and you have the doors and the doors open and the people go in. So that's what's normally supposed to happen. If you see a big crowd of people on the sidewalk, it could be that the door doesn't open, and that's the situation in type 1 diabetes, for example. There's no insulin, so then the door doesn't open, and therefore all the glucose, all the people stay outside. In type 2 diabetes, they imagine a very similar situation to this where there is lots of insulin, but for some reason the insulin is not opening up this door and allowing the people to go in. There's a big problem with this idea, which is one that most doctors still consider to be the way that it works, is that if you think about that restaurant, if the people can't get in, then inside the restaurant it must be empty. So if you translate that to the body, you have a cell, the glucose is outside in the blood, it can't get into the cell, the cell inside should be very empty. And therefore, if the cell has no energy inside, people should be very skinny. They should be very thin. They should have very small, shrunken livers, not big, fatty livers. But in fact, you see the opposite. You see people who are overweight, who have big, fatty livers, and so on. So the cells are not sort of starving. They're sort of overflowing. So if you think about that situation in the bar, there's two possibilities. Either you have a problem with the door, or it could be that the door is wide open, but the restaurant's sort of already completely full, such that you can't push any more people inside. And in that situation, you're still going to have lots of people outside because you can't see inside the restaurant. You can't see what's happening in there. So that's an overflow situation. So I think this is what's happening in type 2 diabetes, which is that the cell really has so much glucose that it can't get rid of, it can't let any more of the glucose into the cell, even though there's plenty of insulin. So the problem is not really insulin. Insulin is doing what it's supposed to do. The problem is that you really have just too much glucose around. So the solution, of course, is to get rid of some of the glucose.
And for a period of time, this works where the body is making more insulin and continuing to drive that glucose out of the bloodstream into cells. And then eventually that whole system breaks, insulin dips, and then blood glucose rises.
Yeah. So for a certain period of time, you can sort of brute force it, right? You can take the people and just shove them with extra force into that restaurant. And then it looks like everything's fine. But the problem is that you've had to use a lot of extra, pushing to get those people inside. So in the cell, what you see is that the glucose has been shoved into this overstuffed cell, right? The cell is stuffed with glucose, but you used extra insulin to really shove it in. So the glucose is normal, but the insulin levels are high. So you know something's not right in this situation. You have hyperinsulinemia, which is where hyper means too high, insulin is, the hormone, and emia means in the blood. So you have too much insulin in the blood. Even though your glucose is normal, you see this hyperinsulinemia much, much, much before you see the increase in glucose. It's only when that sort of, when insulin can no longer, you can't produce enough insulin to shove all the glucose in, that you start to see the problems. So it's sort of like if you have, a luggage, right? You put the clothes in, it goes in fine. Once it gets full, it's hard to put those clothes in and close it. You can, start pushing harder and harder and harder on it, but at some point it's going to stop. And that's what's happening with insulin. Insulin's pushing harder, it's pushing harder, it's pushing harder, but at some point it reaches its limit. And then, no matter how hard insulin pushes, you can't shove any more glucose into that cell. And therefore, that's when the glucose winds up in the blood, and then you get diagnosed with type 2 diabetes. But the process has been going on for a long time before that.
And here's where a big part of the problem lies, what you just touched on there, the fact that this goes on in the background for a period of time. And where the whole quote unquote mistake is happening is the fact that doctors are typically looking at blood glucose and measuring that. So we're looking at the wrong thing, which, coming back to what I said before, we only see that rise once insulin eventually dips after the system's been being trashed for years and years.
Yeah, exactly. So the whole diagnosis of type 2 diabetes sort of hinges on seeing that extra glucose in the blood, but that's a very late stage. It's, sort of 10, 12 years after what's going on has been a problem. And that's, that's based on sort of a sort of old concept of what type 2 diabetes is. There's this concept that a lot of people had mistakenly thought for years that it was the high blood glucose that was causing all the problems rather than the sort of overflowing cells with glucose. So if you have cells that are overflowing with glucose, as long as the blood is normal, there's a feeling that, hey, it's all fine. But it wasn't fine because you had all these other problems going on in the background that weren't being taken care of. So the idea is to try and figure it out at an earlier stage, but also to use, if you're trying to get rid of the glucose, for years there was no good drugs that could do it. There are some now, but the older drugs like the insulin, the metformin, the sulfonylureas, they weren't effective at getting rid of the glucose, and therefore they didn't actually change the underlying problem with type 2 diabetes.
And for somebody who's tuned in thus far and they're saying to themselves, okay, maybe I'm in that big latent stage of even up to a decade or more where I'm starting to become insulin resistant, but I don't have full on diabetes. How does that person begin to understand where they fall in that continuum and whether or not they need to make changes to their diet and lifestyle?
Yeah, you can look at a few things. So the metabolic syndrome is this cluster of sort of 5 things that all go together with high insulin levels. So you have the high blood sugars, of course, that's very late, but you have also high blood pressure. You have a high triglyceride with low HDLs and abdominal obesity. Of course. So you can measure. So they don't actually use body mass index, which is very common for people with weight problems. They use abdominal circumference as a sort of proxy because you tend to store fat for metabolic syndrome more in the abdominal area rather than sort of all around. So the whole idea is that you can look at any of those 5 manifestations of hyperinsulinemia or the metabolic syndrome, and that'll give you a clue because not all 5 necessarily are going to be there. So you could have, say, just high blood pressure and all the other 4 are negative. That could still be a manifestation of hyperinsulinemia, or you may have high triglycerides and low HDL, or you may have just the abdominal obesity. So you can pick that up earlier. You can also use fasting insulin levels and things like that, although that's not typically done as much because there's a lot of variance in the insulin levels. Just like glucose levels, it goes up and down sort of every minute of the day.
Let's get into some of the details of the different health problems that occur along that spectrum of insulin resistance all the way to type 2 diabetes. And to me, there's 2 different issues happening here. One being the increased insulin, and 2, which can be compensated by the increased insulin at times, is the blood glucose. So when it comes to the array of different, you talked about early on the fact that this is affecting everything in the body, but how much of it is because of the insulin? And then how much of it is blood sugar that's not being controlled? And then specifically, what are the challenges
Yeah,
under those umbrellas?
it's almost all due to the insulin, really. The high blood glucose is sort of a downstream problem of that. So we had in the early 2000s several very big, expensive trials where they took people and they basically said, we're going to drive your blood glucose to as low a level as possible by giving you mostly like things like lots of insulin. So essentially, if you think about it, you have this cell that's sort of overfilled with glucose, right? And you're giving a lot of glucose to make sure that the glucose doesn't stay outside and you're shoving it inside. And they thought that that would be very beneficial in terms of reducing heart attacks and strokes and all this sort of thing, because the glucose in the blood was normal. They moved all that glucose into the cell, right? So people were gaining weight like crazy, because all that glucose in the cell, the body can change that into fat. So even while they were making the blood glucose very good, they were making the actual diabetes worse because the cell is just super ultra full, right? So the whole point is that when they took a look at those results, lowering the blood glucose to near normal levels didn't actually make anybody better. In fact, it might have been actually quite harmful. One of the studies showed an increased death rate, so it wasn't good at all. So most of the effect of the type 2 diabetes really is the insulin, which is reflective of the sort of glucose in the whole body, not just in the blood, right? The blood is only one component of the body. There's also the rest of the organs and inside the cells and so on. And there's just glucose sort of everywhere in there. And just taking it out of the blood and shoving it into the liver doesn't really help. You're simply moving around the problem of the excess. Sort of like if you have garbage and instead of throwing it out, you just put it under the sink and keep putting it under the sink. Well, you can't see it anymore. So you think you're doing great, but it still smells. So it's just like that glucose, right? You keep taking that glucose and instead of getting rid of it, you just shove it into the liver. Well, eventually it causes more problems because you actually haven't done anything about the excess. The excess is still around. The minute you stop taking that insulin, all that sugar just comes, rushing back out because, you haven't gotten rid of it.
So we've uncovered the fact that insulin is the main problem here. When along that spectrum of insulin resistance do people start having issues with chronic disease? I'm sure it's going to depend on the person, their genetics, a lot of different variables. But what I'm getting at here is how long or how often actually do people have a chronic disease in that period before type 2 diabetes strikes?
It can be long. I mean, the whole transition can take, 10, 15, 20 years, which sounds like a long time, except that a lot of people are developing type 2 diabetes now in their childhood because of dietary issues. So we see, it used to be if you had diabetes as a child, it was type 1 diabetes. Now it turns out that there's a lot of type 2 diabetes as childhood obesity has sort of exploded, sort of thing.
But it doesn't take pushing it all the way to diabetes, whether it be an adult or child, to start suffering from chronic disease, correct?
Yeah, you can start getting it fairly early. So it's sort of like a good news, bad news thing. That is, if you pick it up, you can catch it early on, right? If you know about it, you have a long time to sort of deal with it. On the other hand, once it develops, it's really hard to reverse. So that's really one of the problems. So it can start, very early within a few years. This is so from the process happening. That's not from when you make that diagnosis. That diagnosis can stay hidden for a long time. Like if you don't do your blood test, if you don't do your, if you don't, check your waist, your weight, your blood pressures, then it can be a long time before you pick it up. Like you may have had it for some people may have had it for 10 or 15 years before they pick it up and then have already had the chronic diseases starting to take hold. So I see this a lot actually. So one of the places that you can see it relatively early is you can see it in the urine. So I get referred a lot of people with protein in the urine, and one of the things that is happening is that they're starting to get this diabetic damage to their protein. So that we see this protein sort of spilling out in the urine, and that's the first sort of thing that is noticeable. They don't even know that they have diabetes. So certainly you can see the damage before you have the diagnosis. But, if you were to look back in time magically somehow, you would still see that actually had happened, like things had happened a long time ago. You just didn't know about it. So on the one hand, there is time. On the other hand, you have to really be aware of it and looking for it.
And whether or not somebody knows that their insulin's elevated, most likely they won't know unless they're tuning into something like this and having their fasting insulin tested. But what I'm curious about is the more serious health conditions that happen before even diabetes can strike due to that chronic insulin being produced en masse in the body.
Yeah, for sure. I mean, the whole, I see people with diabetic kidney disease that don't even have diabetes. And it's because metabolic syndrome, of course, is this constellation of 5 things. So you may not have the diabetes, but you may still have this associated, we call it diabetic kidney disease, but it's actually metabolic syndrome associated kidney disease. So it certainly can happen early, and that's why you always have to be on the lookout for it. Once it develops, it's really hard to sort of go down.
But what I'm getting at there is there can be even things like heart attack and stroke, cardiovascular disease from the insulin being chronically elevated.
Oh yeah, insulin is actually well known, and I don't know why people don't sort of clue on, but insulin's actually really, really well known to have proatherogenic effects. That is, it causes the hardening of the artery, the narrowing, all of those things. So the process of developing a heart attack is because you get a narrowing in the artery of the heart in the brain. It's a stroke. And everybody assumes that it's because cholesterol basically clogs up your artery. That's probably not true at all. And even when I was in medical school 30 years ago, we talked about this. And it's that idea that you're just clogging up the artery with cholesterol is completely wrong. I mean, they taught us that in 1990. So this is, 30 years later. I don't know why we still talk about clogging up the arteries with cholesterol. But essentially, what they're saying is that the reason these arteries get blocked is not because they get clogged with cholesterol. It's a response to injury hypothesis. That is, there's an injury to the endothelial cell, which is a cell that binds the artery. And then you get things like smooth muscle proliferation. And then from that, you get infiltration into the artery from this cholesterol. But the inciting incident is really an inflammatory response. It's this sort of idea that it's the inflammation and it's the smooth muscle proliferation that's the problem. And insulin's well known to contribute to all of those things. So I'm not sure why we're so sort of fixated on cholesterol. I mean, sure, it could be one of the factors, but it's not a major factor. I mean, look at the major factors of heart disease, right? Cholesterol is not even close. Smoking is way worse, and diabetes is way worse. I mean, there was just a study like a week ago, looking at the effect of, various risk factors and so on. And by far and away, the 2 most important things, especially in younger people like 50 or less, is smoking and diabetes. Like cholesterol didn't even make a dent. It was, the risk of so diabetes sort of either double or tripled your risk of heart disease, whereas a high cholesterol didn't change it barely at all. Smoking did the same. It sort of doubled or tripled your risk. So very interesting, because those are not cholesterol-based things. They're inflammation, insulin. There are lots of studies on other treatments, such as like colchicine, which is an anti-inflammatory, which may be very useful in the treatment of heart disease, that have nothing to do with cholesterol. So we're so sort of focused on the cholesterol that we're sort of missing all these other things that we know about. Because smoking doesn't raise your cholesterol, right? It has all sorts of other bad effects, but cholesterol is not one of them. So for all those people that sort of say, oh, it's all about cholesterol causing heart disease, like, no, there's like a ton of other issues. Cholesterol could be an issue, but there's a lot more important issues. Diabetes being one of them by far and away. And nobody talks about that. High insulin is one of them.
We keep hammering home this point that there's this period of time, this latency before type 2 diabetes fully manifests, where people are insulin resistant, insulin's chronically elevated. As you're explaining there, it gets me curious thinking about people that have heart disease before diabetes versus after. Like, how many people within that decade of insulin resistance before they were even diagnosed with diabetes have heart disease versus somebody who's way down the line and has been suffering with diabetes? You probably don't have an answer to this, the percentage wise, but do a lot of people end up having that heart disease way before diabetes even strikes?
Well, there's a lot of different things that cause heart disease. So I'm sure it's a continuum. That is, there's different, some people it's going to be a minor contributor and other people it's going to be a major contributor, right? But there's other things like age and sex and, genetics and exercise and smoking and cholesterol and, there's just this whole other issues, right? So if you look at risk factors for heart disease, there's a whole bunch of different things. So I'm sure that diabetes contributes. It's a major contributor for sure, but in any particular person is going to be that combination of things, right? So men tend to get it younger than women. Women are protected until they're postmenopausal, for example. So there's all these sort of different things that go on that contribute. And for each individual person, it's going to be variable. But for sure, diabetes could be one of the major contributors. And the important thing about it really is that it's a reversible risk factor, right? So age is probably more important than anything else, but you can't do anything about that. So, and same with genetics. Genetics is probably much more important than any of the factors we talked about, but you can't do anything about it. So why worry about it? You can't, you can't change any of that. Whereas smoking, for example, you can change. And diabetes, which was considered not reversible up until sort of like a year ago, which is sort of blows my mind, right? This is what I wrote about in the diabetes code, is that it's unbelievable that every doctor considered type 2 diabetes as a chronic and progressive disease when we know that it's actually reversible. You can get your sugars down into the normal range. So therefore, you can reverse your type 2 diabetes. So that's what we should be aiming for. And people were like, oh, no, that's not possible. I was like saying, that's a complete lie. So I wrote that. The book was published in 2018. I've been writing about it since like 2013. So 10 years ago. And it wasn't until 2021 that the American Diabetes Association put out criteria for remission, basically admitting that it's a disease that can be reversed. And the Canadian Diabetes Association didn't put that out until this year. It's like, the fact that they couldn't see what was sort of super obvious, that you need to get people to change their diet, to lose weight, to reverse that diabetes. Like, everybody with any type of logic could see that was true, and yet they were denying it, right? These are the doctors and the specialists, right? So it's sort of mind-blowing that that these sort of, conventional specialists were so, blind to the fact that you could actually reverse this disease.
Well, we're going to get into the specifics of how people can do that, how they can lose weight, coming back to our sugar bowl, how they can start dumping out that sugar in the body that's been accumulating. But before we do that, I want to make sure I tease out the point I was trying to get at, where people might not get to the full stage type 2 diabetes. And the way I understand it, and I'll have you clarify, is they could still have heart disease or stroke in that period of time where they're just insulin resistant.
Yeah, absolutely. So the point is that the disease of the hyperinsulinemia goes way, like, a decade or more before you actually get the diagnosis of type 2 diabetes. So therefore, that period of time where you're still hyperinsulinemic, that insulin is still contributing to the development of the atherosclerosis, which is the hardening of the artery, the narrowings, and so on. So it's not as bad as if it was type 2 diabetes, but it's actually starting in that period. So you don't have to have diabetes. You're getting a contribution from that hyperinsulinemia long before
And part of the scariness of that situation is people, when they're insulin resistant, they might not actually be overweight or obese. There's a certain group of that population that will appear skinny and still be suffering from increased insulin on a chronic basis, like we're talking about.
Yeah, absolutely. And that's the thing about the body mass index, which is a little bit deceiving at times because it only takes into account height and weight, for example. If you have very high muscle mass or very low muscle mass, then of course that weight is going to be not a very accurate reflection of, body fat versus lean mass, sort of thing. So it's definitely one of the things that you do have to sort of make sure that you look at in a little bit more detail than just say you were skinny. And I remember looking at data a while ago in China. They have a lot of type 2 diabetes now, and their average body mass index, I think, of people getting the diagnosis was like 24.3 or something like that, which is, if you look at the body mass index, under 25 is considered normal weight. So these are all, on average, normal weight people by body mass index that were getting type 2 diabetes. Right, that's sort of scary. In the United States, it was closer, I think, to 27 or 28. So people were overweight when they got the type 2 diabetes. Whereas in China, for example, they get at much lower body weights. I think for South Asians, that's true as well. So they typically they don't look like they should have type 2 diabetes because they look relatively okay, but they still have it.
If you enjoyed that clip, press here for the full episode. I'll see you over there.
Insulin's pushing harder, it's pushing harder, it's pushing harder, but at some point it reaches its limit, and then no matter how hard insulin pushes, you can't shove any more glucose into that cell, and therefore that's when the glucose winds up in